You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for March 16th, 2018, an ACC recap show. The topics that I'll talk about include the Black Barbershop study, the mSTOPS study, the ODYSSEY outcomes trial, the VEST trial, two studies looking at genotyping, LVADs, and canakinumab. First up is the Black Barbershop study. By far, hands down, the best study coming from ACC, perhaps the best study I've seen in years. It did not involve any new devices or expensive new drugs. It did not even include doctors or medical centers. It dealt with black men, and black men with hypertension do terribly. Observational studies confirm it, but more importantly, we have all seen the complications of hypertension in black men: heart failure, kidney failure, stroke, and early death. That's why the genius idea to take blood pressure control into black barbershops is so important. The idea began way back, I think in the 1990s, with the late Dr. Elijah Saunders from the University of Maryland. This work has also been carried out by a group in New Orleans as well. Researchers from Cedars-Sinai in Los Angeles conducted a novel trial of an intervention versus control. The barbershops in the intervention group had barbers who encouraged the patrons to follow up with pharmacists who came to the shop regularly. The pharmacist then followed a tiered prescription plan of medications. The control group, on the other hand, simply had barbers that recommended follow-up with a PCP and healthy lifestyle. More than 100 black men were enrolled in the two arms, and those in the intervention group sustained average blood pressure drops of more than 20 millimeters compared to the control group. And more than two-thirds of hypertensive men in the intervention arm reached a goal blood pressure of less than 130/80. My friends, I encourage you to read this study. It was published in the New England Journal. Read it again. This is fantastic work. There is much to celebrate. Think about it. Huge improvements of blood pressure in a super high-risk group. The pharmacist led the prescribing. This was community-centered outreach. Crucially, this is steep of the curve spending. It's high-value stuff. Lots of benefit at low cost. Second topic is AFib screening. Now, we know patients diagnosed with AFib in the regular way, with office ECGs that are prompted by symptoms, have a higher risk of stroke, and if there are more than 2 risk factors for stroke, these patients do better with oral anticoagulants. This we call clinical AFib. We also know lots of patients have non-symptomatic AFib. Thus, it makes perfect sense that looking for AFib in people with risk factors should be a good thing, right? If we find AFib, then we can treat them and they will do better. Now, the mSTOPS trials tested this idea. This came from Scripps researchers in San Diego. They scanned an Aetna insurance database, and they offered study participation, basically monitoring with a Zio patch being a 14-day Holter monitor, to older patients with risk factors. This I call smart screening, right? Because it's where researchers only went after people they knew might benefit from oral anticoagulants. Of 100,000 people invited, they got about 2,000 to participate in the trial and found a 3-fold increase in AFib diagnoses. About a third of the episodes were greater than 6 hours. Most episodes were short. Now, about 9% of patients discovered had greater than 24 hours of AFib. The actively monitored group versus a control group was slightly more likely to get a new anticoagulant prescription, and this group also got more health care. They saw their PCP more often. They had cardiology visits more often. Interestingly, the actively monitored group had more pacemaker and ICD placements. It was 13-0, active versus control group. However, there were no differences in the rates of stroke or MI. though this wasn't a primary outcome of the trial. More than a third of patients who agreed to be in the study never wore the monitor patch, so that's a significant limitation. So my conclusions from this is a sobering reminder that screening is admirable, but in real life there are snags. When you monitor people, especially older people, you're going to find AFib episodes, so-called subclinical AFib. Then these people utilize more healthcare, for sure. But it is not clear that making the diagnosis and treating these patients improves outcomes. It's very concerning to me that there's a 13-0 rate of device implants. There are two ongoing trials called NORA and ARTESIA which are looking at treating subclinical AFib, and these will be pivotal landmark trials for sure. Next up is the ODYSSEY Outcomes trial. Now with the FOURIER trial, we learned that evolocumab modestly reduced non-fatal events in at-risk patients with stable coronary disease, but that drug did not result in a mortality benefit. So the PCSK9 inhibitor drugs have not really taken hold, probably in large part because of price and also these modest benefits. At ACC, we learned the results of the slightly longer ODYSSEY Outcomes trial with alirocumab. ODYSSEY enrolled patients after acute coronary syndrome, and crucially, these patients were on intense statin therapy, about 90% on max dose atorvastatin or rosuvastatin. Alirocumab reduced LDL levels by about 50%, and this translated to a 1.6% absolute risk reduction in major adverse cardiac events, MACE, so it was 9.5% versus 11.1%. That's a 15% relative risk reduction. For the secondary endpoints, alirocumab reduced all-cause death by 0.6%, but statistical testing revealed a nominal p-value of 0.026. This p-value is considered exploratory because neither coronary heart disease death nor CV death was lower, and they fell above the all-cause death in statistical testing. There were no safety issues during the 3 years of follow-up of this study. Now, the most discussed aspect from ODYSSEY was the subgroup analysis, and the subgroup analysis was broken down by baseline LDL. Here, the investigators analyzed outcomes based on levels of LDL less than 80, levels of LDL between 80 and 100, and then levels greater than 100. Alirocumab did not significantly lower either the primary outcome or all-cause death in the first two groups, but did show significant reductions in the group with LDL levels greater than 100. Specifically, in this group with the high LDL levels, alirocumab reduced the risk for the composite endpoint by 3.4% and all-cause mortality by 1.7%. So those gains were greater than the gains in the overall trial population. We also learned during the ACC that the makers of alirocumab have proposed lower prices for their drug. Now, I think this study changes things. The subgroup of patients with severe coronary artery disease who have an LDL greater than 100 on high-intensity statins is small, but with lower prices of the drug and more significant results in this subgroup analysis, I think payers will probably start covering for this prescription. Perhaps a larger group are those with the coronary artery disease and an LDL greater than 100 that's due to statin intolerance. And if ezetimibe doesn't get them below 100, then PCSK9 inhibitor drugs may be useful in this group. Now, it's funny that the old school notion of just getting to below 100 may make a resurgence after this subgroup analysis. Now, our site has 4 studies on this trial, a superb news story, my review. My colleague, Dr. Melissa Walton Shirley, has comments on it, and I did an interview with co-chair of the trial, Dr. Greg Schwartz, who was an excellent explainer of the trial. Next topic is the VESS trial. Now, for more than a decade, the wearable cardiac defibrillator has been widely prescribed to patients during waiting periods after MI and other waiting periods as well. Before the VESS trial, evidence for this practice came from industry-sponsored registries and anecdotes alone. Real defibrillators, ones that are automatic, implanted and present 24 hours a day, have failed to improve mortality in these high-risk patients in multiple randomized controlled trials. The VEST trial tested whether the WCD, the wearable cardiac defibrillator, could do better than real ICDs. The bar was set pretty low. VEST investigators chose only high-risk patients. These were low EF after myocardial infarction. They chose sudden death, not overall death, as the primary endpoint, and the trial lasted only 3 months. Now, interestingly, it took up to 10 years to recruit patients in this trial. The randomization was 2-to-1, and about 2,300 patients were randomized to the WCD or no WCD. The primary endpoint was negative. Let me repeat. The primary endpoint was negative, 1.6% versus 2.4%, and the p-value is 0.18, so not even close to significant. But the big story at ACC was the spin. The VEST trial noted a lower non-sudden death rate in the WCD arm, and all-cause mortality was lower. It was 3.1 versus 4.9%, and that p-value just sneaked under 0.05, and it was 0.04. But crucially, this was a secondary endpoint. Now, the primary investigator and presenter, Dr. Jeff Olgan from UCSF, speculated that there may have been misclassified deaths. In other words, some non-sudden deaths were actually sudden deaths. He also speculated that the VEST might have other beneficial effects, like better medical compliance and reduced anxiety. Now, Zoll Medical, the makers of the wearable cardiac defibrillator, had banners up throughout the conference center advertising the relative risk reduction of a secondary endpoint in a trial that had a negative primary endpoint. And something rare happened during the question and answer session of the late-breaking clinical trial announcement. I hardly ever see this. Normally, the Q&A after a late breaker is a celebration. The questioners are often friends who basically give the speaker academic high fives. They celebrate and help promote the trial. Or if the trial is negative, the questioners can find something positive about it. But at the VEST trial, 2 leading voices in cardiology, Dr. Patrick O'Gara and Dr. David Wilbur, actually questioned Dr. Olgan, the presenter, and the questioners actually expressed doubt. Now that was telling. In my area, the wearable cardiac defibrillator is marketed to general cardiologists with fear and anecdotes. The WCD is expensive, up to $10,000, and it's burdensome to the patient. And I hope this negative trial puts an end to indiscriminate, fear-based prescribing. I also hope it sends a signal to the FDA to reconsider the ease with which such medical devices get through the regulatory process. Next topic is genotyping strategies. So 2 studies presented as featured research at ACC suggested genotyping patients with ACS may be useful. Now, I qualified these statements with the words suggest and may be because the studies have limitations. The first one, PharmClo, an Italian study, which had a simultaneous publication in JACC, found that patients who received genotyping to guide the choice of meds were significantly less likely to experience a primary endpoint event. And the primary endpoint was a typical composite endpoint, compared with patients who did not receive the genetic test. The problem here with this study was that it was stopped prematurely by Italian authorities after only about a quarter of the 3,600 patients were recruited, and this means that confidence intervals are going to be wide. Also, in the PharmClo study, bleeding rates were lower in the arm that received genotype testing, which is very curious because more patients in the gene testing arm were taking ticagrelor and prasugrel, drugs known to increase bleeding. Now, the second study also presented at ACC called the ADAPT-PCI study, and this was from UPenn researchers, and it was a pragmatic RCT looking at point-of-care genotype testing after PCI. And the endpoint, the primary endpoint, was the number or proportion of participants using prasugrel or ticagrelor, and outcomes was a secondary endpoint. And the UPenn researchers found genotype testing did indeed significantly influence antiplatelet prescribing. Genotype-guided recommendations were followed about 71% of the time, but prior antiplatelet therapy influenced the choice. So in other words, patients were on a certain antiplatelet, doctors tended to use that. Clinical outcomes in this study did not differ, but the study was underpowered for that outcome. Now, my take of both of these studies is that it's not enough to change practice. Bigger studies are underway, but even then, I am not sure genotype testing is going to make a difference. Again, remember, platelet reactivity measurements did not change outcomes, and genotype is but one component of determining how platelets function. Next topic is the Momentum 3 trial. This one's easy. A new LVAD, the HeartMate 3, performed better than the HeartMate 2. Lower stroke rates, less pump thrombosis, and less reobs. Now, obviously, iterations of devices like LVADs are important, but I'm not sure how this rises to the level of the New England Journal of Medicine. Well, I have an idea, but I'll keep my speculation to myself. As reported by ACE reporter Marlene Busco, these 2-year data will be part of an application to the FDA for use of this device for long-term destination therapy for heart failure. The final topic is on canakinumab. Now remember canakinumab? It's the IL-1 beta inhibitor that produces anti-inflammatory effects. And in the CANTOS trial, it led to a modest reduction in non-fatal cardiac events independent of LDL lowering. At ACC, the CANTOS team of authors tested the hypothesis that this anti-inflammatory drug would reduce incident diabetes. And despite large reductions in high-sensitivity CRP and interleukin-6, canakinumab did not reduce the incidence of new-onset diabetes at any of the tested doses. So that's it for this week in cardiology. It's a little bit longer podcast than normal. The ACC is a big meeting, so thanks for listening. I'm grateful that you listened. This is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.